This is Charlotte Talks. I'm Tom Bullock in for Mike Collins. It's a promise every Republican in Congress has made time and again over the past 7 years. Repeal Obamacare and replace it with something better and cheaper. Just what, though? America would have to wait and see. When the first plan emerged in the U.S. House earlier this year, Republicans knew it had problems. Tens of millions left uninsured, many of them poor. In passing the plan, the representatives left it to the Senate to come up with something better. So a small group of Republican senators met behind closed doors and worked something out. The results may be even more controversial than what was hashed out in the House. This hour, we go through the Senate health care bill and explain what the plan would do and what it would cut. But we'll also go beyond the numbers and policy points and explain how it could affect health care here in the Carolinas. If you're a longtime NPR listener, our first guest is a voice you know well. For years, Julie Rovner covered health policy for NPR, including the crafting and rollout of Obamacare. She is now the chief Washington correspondent for Kaiser Health News. Julie, it's always a pleasure to talk to you.
Always a pleasure to talk to you, Tom.
And Don Jonas has also been on our air before. He's the executive director of CareRing, which provides health services to at-risk populations in the Charlotte area. Don also teaches at the Blair College of Health at Queen's University, and thanks for coming into the studio today.
My pleasure. Thanks, Tom.
And finally, we have Steve Lawler on the line. He is the incoming president of the North Carolina Hospital Association, which represents 130 hospitals across the state. Steve is currently senior vice president of the regional group for Carolina's healthcare systems. And Steve, welcome to Charlotte Talks.
Thank you so much.
Now, I'm sure you have questions about the U.S. Senate healthcare plan, and we'd love to hear from you, our listeners, this hour. So send us an email. charlottetalks@wfae.org is the address, or you can search for us, search for Charlotte Talks on Facebook and Twitter. And I want to start here with the big news, which is yesterday, the Congressional Budget Office released its score of the Senate healthcare plan. And Julie, I know you've been covering this quite a lot. So just explain to us briefly, who is the CBO and what are their findings?
Well, the Congressional Budget Office is the official scorekeeper for Congress, and in a budget exercise, which is actually what this health bill is in the Senate, they basically determine, what happens. There's a lot of people who are now, criticizing the CBO for not always being right, but in fact, CBO was closer in its estimates of what the Affordable Care Act would do than many people are suggesting. Anyway, what it found with the Senate bill is that at the end of 10 years, there would be 22 million more people who would be uninsured. 15 million fewer people would have coverage through the Medicaid program. 7 million fewer people would buy their own insurance. The bill, as it's structured, would save the federal government about $320 billion over 10 years. That's in deficit reduction. That's almost $200 billion more than the House would save. So the Senate has actually theoretically some money to play with if it wants to make some changes here.
And I want to clarify something you said there. You're talking about some criticism of the CBO. A lot of that has come from Republicans who, knowing that the CBO score could be a problem point for them, have come right out and said, oh, the CBO is not great at estimating health care coverage or dealing with these kinds of bills. But you believe, at least when you compare it with Obamacare, that in fact they have been pretty accurate.
Yeah, the big complaint that and the White House has been sort of leading the charge against the CBO, even though I would point out that the head of the CBO changes with party control. So the head of the CBO right now is a Republican who is in fact chosen basically by Tom Price, who's now the Secretary of Health and Human Services, but at the time was the head of the House Budget Committee, which is who selects the head of the CBO. What the White House was saying, what Tom Price was saying over the weekend, is that the CBO estimated with the Affordable Care Act that there would be 23 million people who would be buying insurance from the health insurance marketplaces. And in fact, that number is closer to 10 or 12. But the main difference is that the Congressional Budget Office assumed that a lot of employers would stop offering coverage, particularly small employers, and send their employees to buy their own insurance. And for a variety of reasons, which included the fact that there was a lot of difficulty rolling out the exchanges, most employers haven't done that. So that was the main difference between what the CBO estimated and what actually happened.
All right, let's get back to the current U.S. Senate health care bill. And it's Republicans, whether they believe the CBO score or not, it is a problem point for them. I want us to take a quick listen to something that South Carolina Senator Lindsey Graham had to say about the CBO score.
How you put all this together and get to 50 is going to be very tough, and the CBO score doesn't help any. If you had problems with the bill before, you probably got more problems now.
And that, again, is from South Carolina Senator Lindsey Graham. There are other issues with this bill that also deal with premiums. The Republicans, again, have promised the core point is to make premiums for individuals drop. And Julie, and I'll bring our other guests here in just a second, but Julie, the CBO picture in terms of premiums, it's kind of mixed.
It is. Well, premiums do drop, but premiums drop because the insurance that the premiums would pay for would be less generous. So if you don't use your insurance, if you're young and healthy, you might actually get a little bit of a break. However, if you are sick or if you need services at all, then you're going to pay more at the back end. And the reason for this is that there are still tax credits. They don't go as high as they do under the Affordable Care Act, but they're based on a plan that is significantly less generous. Right now, they're based on a plan that's supposed to cover 70% of your health care costs. Under the Senate bill, the credits would be based on a plan that only covers 58% of your health care costs. So if you use health care, even though your premiums would be lower, you'd end up spending more out of pocket. And that's the problem that people have. It's not just that premiums are too high, it's that deductibles and other, costs they're expected to spend are too high. And this would only take care of one piece of it, make the other piece worse.
Now, Steve Lawler, I want to turn to you for a moment because all of these numbers must concern the group that you're associated with. You are the incoming president of the North Carolina Hospitals Association. What are your thoughts so far on this bill?
Well, first of all, I would say that, our hospitals in North Carolina as well as, hospitals throughout the country, have been really guided by a set of principles that, focus on expanding coverage and making health care accessible to people throughout the country. And another principle certainly is to see if we can craft kind of a bipartisan solution to health care. And unfortunately, it looks as if we're in a situation where the best ideas that are offered by both parties go unnoticed. So in North Carolina, I think there's great concern in regards to what's going on, with the Senate bill. And I think what's at stake, really is the health of the people of North Carolina and the health of the medical community, and that includes hospitals and physicians and other professionals that are caring for those people. So we're concerned that under this bill, more than 500,000 people, in the state will lose access to affordable insurance. That
and to clarify, Steve, that's 500,000 people just here in North Carolina.
That would be correct.
And with that kind of a hit, forgive me for interrupting, but with that kind of a hit, I wonder too, because hospitals in rural areas of America and rural areas of the Carolinas can often be the single largest employer, and obviously are the key point of health care for rural Americans. Is there a risk that these kinds of cuts, and we'll get into Medicaid in a moment, but these kinds of cuts are this making health care potentially less affordable for 500,000 North Carolinians just here in the state? What kind of an impact could that have on rural hospitals?
I think the trickle-down effect is pretty significant. I had the privilege of being the president of a critical access hospital in Bertie County, and 75% of our patients were either Medicaid or Medicare, and over the past 6 or 7 years, hospitals have been asked to take payment reductions to help underwrite the Affordable Care Act. I think the American Hospital Association worked with President Obama and took a $155 billion reduction in payment over 10 years to help underwrite expansion as well as the exchange. So I think when we see an increase in the number of uninsured, and some of that deals with the exchange, some of that deals with changes in Medicaid, the impact is that safety net hospitals and safety net providers in small communities who are already being paid less than cost for caring for these patients, are at risk. And you're right, hospitals in many communities are the largest employer. They're kind of a source for economic stability and growth. but it does place those in peril.
And I want to turn now to Don. We're talking about critical access points. I mean, you caring is a place where people who cannot afford classic health care coverage can go for services. What kind of an impact do you think, if it actually passes, if it then became law, what kind of an impact could this have on the types of people Caring sees?
Yeah, so Caring is a nonprofit clinic. We don't process public or private insurance, and we're just there for people that have sort of fallen between the cracks. And in Charlotte, that's upwards of 60 to 70,000 people that don't qualify for insurance, are not eligible for Medicaid. Our healthcare community would rather not have folks showing up at the emergency room, so they're coming to us. If this bill were to go forward as it is, we would anticipate there would be an awful lot of more people that would not have private insurance, that would then have to rely on access points like ours in order to provide care. Now, there's an additional challenge with this because we're not a place that processes Medicaid. We work in our businesses on very tight margins, but some have said maybe we should consider looking at becoming a Medicaid provider. But I know we're going to get to Medicaid here in a little bit, but it could be that we're moving into an environment where the payments for Medicaid and the eligibility requirements for Medicaid could become so onerous that it becomes much more difficult for access points like ours to be that sort of a provider. So this introduces a new environment in Charlotte and really across the country where providers like ours, if this bill or something like this bill went forward, we would have to work much more collaboratively with our hospital partners in order to provide care.
And Julie, let's get back to some more of the meat here, too. Two key points that were always part of the debate when it comes to health care: pre-existing conditions and a phrase that many Americans may not know by heart, essential health benefits. Are pre-existing conditions covered under this plan? And what about essential health benefits?
Well, the answer is yes and no. Unlike the House bill, both the House and the Senate bill have options for states to come in and waive some of these requirements. Basically, one of the most popular parts of the Affordable Care Act was requiring insurers in the individual market to sell to people who have pre-existing health problems and sell it to them at the same price they sell to everybody else. In the past, either you got charged very much more, or they turned you down entirely. In exchange for that, because everything is a trade-off, the Congress put in the individual mandate that everybody hates, that says that you have to have insurance or you pay a tax penalty. And the reason for that, of course, is that if only sick people were to sign up for health care, insurance companies couldn't afford it. They would go broke. They needed healthy people. So you need some kind of enticement for healthy people to sign up. The House has a continuous coverage provision where if you have a break in coverage, you have to pay a 30% higher premium for a year. The Senate just yesterday added a provision that's called a 6-month lockout that says if you have a break in coverage, then you'd have to wait 6 months before you could get coverage again. The Congressional Budget Office, by the way, said that would have kind of minimal impact on the state of the risk pool. So the essential health benefits, of course, say what insurance policies have to cover. They were also controversial because people say, well, why do men have to buy maternity coverage? But that's because if you can't spread maternity coverage across a large piece of the population, it would be too expensive for just the people who are going to need it to buy. So the Senate bill would allow a waiver of some of these provisions. Interestingly, because there's so many interactions in healthcare, if the Senate waives the essential health benefits, then they would lose a protection for annual and lifetime limits, something that's also very popular. So it's all complicated.
And we're going to dig into that here in a second. Up next, the story of a 6-year-old and her family's fears about the Senate plan. That and more after this break. You're listening to Charlotte Talks here on 90.7 WFAE.
Support for Charlotte Talks comes from WFAE members and Tyndall Subaru Gastonia, featuring the new Outback with eyesight safety technology that sees problems and initiates action to help avoid trouble. Details at tyndallsubaru.com. And America's biopharmaceutical companies. Every day, 140,000 researchers across the country, including thousands in North Carolina, search for tomorrow's breakthrough cures. More information at goboldly.com. Tomorrow on Charlotte Talks, just when you thought election season was over, filing starts next week in the race for Charlotte Mayor, a contest that could set a record for fundraising. Some of that money is expected to come from groups whose donors are allowed to remain secret. It's a new type of political activity for Charlotte, and we'll take a closer look. Then we welcome Charlotte native Abby Corrigan back home as she prepares to take the stage as one of the stars of the Broadway tour of Fun Home. That's when Charlotte Talks, tomorrow at 9 on 90.7 WFAE.
I'm Tom Ashbrook. Coming up on the next On Point, could the Senate health care bill make the opioid crisis worse? We'll look at how deep cuts to Medicaid could hobble efforts to save lives. That's coming up on the next On Point from NPR.
On Point coming up at 10, right after Charlotte Talks, here on listener-funded 90.7 WFAE, Charlotte's NPR news source.
This is Charlotte Talks on 90.7 WFAE. I'm Tom Bullock. We're talking the Senate health care bill with Don Jonas, Executive Director of Care Ring, Steve Lawler, the incoming president of the North Carolina Hospitals Association, and Julie Rovner, Chief Washington Correspondent for Kaiser Health News. You can also join the conversation. Search for WFAE on Facebook and Twitter. Now, health policy is about a lot more than just numbers, and we've been talking numbers so far, but at its heart, health policy also affects lives in sometimes very difficult times. So I want to start this segment with a story written on construction paper, complete with crayon drawings. The author and illustrator is 6-year-old Clara Hardy, though her mom helped her with, writing out the big words as you would need to do with a 6-year-old. The fact that Clara is 6 itself is remarkable. Her book explains why. This is from an upcoming story by WFAE's Alex Olgan.
When I was born, I couldn't breathe. The doctors put machines on me to help me. I had a congenital diaphragmatic hernia. On day 8, the surgeons cut me open. Everything that was in my chest got moved back to my belly. They put a patch to fix the hole in my diaphragm. After surgery, I got very, very sick. The doctors thought I would die, but I didn't. It still took me a long time at home to heal. My scar on my tummy makes me proud. It is a reminder that I am tough and I can do hard things.
Clara spent the first 2.5 months of her life in the hospital. Robert Hardy, Clara's dad, says her medical bills totaled more than $1 million. And he is worried that insurance companies are allowed to limit how much they spend on someone during their lifetime. His daughter, the 6-year-old, may have already hit that threshold.
Lifetime limits. I don't really know what that limit would be, but there's a very good chance that she's probably already hit it. Secondly, if we are doing away with the requirements of covering the essential benefits, hospital stays, surgical visits, any of that type stuff, then we could be faced with not having a plan available to us that covers what she might need to keep us solvent as a family economically if something else were to pop up and she needs to have another surgery.
Now, first, I want to thank Alex and the Hardys for sharing Clara's story. And I'd like to answer Robert Hardy's question. Would the Senate plan allow insurance companies to limit how much they spend on a patient in their lifetime? Julie, I think you were alluding to this earlier.
That's exactly what I was alluding to, and the answer is it could. It's not. They don't waive it specifically. They don't get rid of it in the bill, and part of that reason is because they're doing this special budget procedure that lets them pass the bill with only Republican votes. But there are very strict rules around what you can include in those bills, and so they probably couldn't go in and take that out. But because of the waiver that they're doing, states could waive the requirement for the essential health benefits. What I was talking about, that every insurer has to offer a specific list of 10 benefits. And it turns out that the bans on lifetime and annual limits in insurance are tied to those essential benefits. So if you got rid of the essential benefits, you also get rid of the ban on lifetime and annual limits. It's a little bit attenuated, but it could indeed happen.
And I mean, it's worth noting that Clara's condition is relatively rare, but the Hardys' story as a family is likely not. And some people will point out, well, they could probably go to a hospital. They could go to a clinic and get some charity care. And there are some charitable hospitals in the U.S., but let's face it, the vast majority in the country, the vast majority of hospitals, they're businesses that have payrolls to cover. They have expenses that they need to cover in order to stay open. Steve, as a representative of the Hospital Association, Are you worried about the loss of these potential loss of these essential health care benefits and the lifetime caps and how that would hit your bottom line?
Of course, I think our state's hospitals and hospitals throughout the country are concerned. I would say that that our hospitals in North Carolina are just incredibly committed to serving everyone who walks through the door. And I think in these cases as well as others, our hospitals are standing watch and ready to care for patients and families, regardless of their ability to pay, regardless of their insurance status or what they look like. So I think in essence, this kind of provision, would drive up, the cost of care for all, because hospitals would then be required to spread that expense, to those people who have insurance. And it would also result in, additional write-offs and write-downs because, what perhaps was covered before, now may be shifted over to uncompensated care or charity care. And as that builds, in essence, it forces hospitals to really take a hard look at those mission-based services that we provide. An example would be, women's and children's, or trauma, or disaster preparedness. Those are all services that are incredibly important to the public and the people that we serve. But, they are funded, through, other lines of businesses and or services within the hospital that tend to be a little more profitable. So, I think it is a concern. I would say that, that North Carolina hospitals have a proud history, reputation of, being there when people are in need, and that's delivered regardless of their circumstances.
And we have some questions that are coming in I'd like to get here in just a moment, but I do want to bring up Medicaid as we promised, because this is a significant portion of this plan. Of the roughly, and Julie, correct me if I'm wrong, of the roughly 22 million people who would potentially lose their health coverage over the next 10 years, about 15 million are Medicaid recipients. This plan would almost completely revamp the way Medicaid works, Julie. Is that correct?
Yes, this goes way beyond repealing the Affordable Care Act. This reaches back to the origins of the Medicaid program in 1965, where the federal government said to states, there are certain people, low-income people, who are going to be eligible for health care. If you pay your share, we'll pay our share. And in fact, the federal government pays at least half of Medicaid costs, and much more in states with larger poor populations. What this is saying is that the federal government is going to retreat from that promise and say, we're going to give you a certain amount of money and no more, and we're going to let it rise each year according to a slower measure of inflation than Medicaid and medical care in general has traditionally risen by, which the Congressional Budget Office estimates will end up squeezing 15 million people off the rolls. States are upset about this. Even the National Governors Association, which is a bipartisan group that has had trouble agreeing on much of anything in the last few years, sent out a letter that said, this is going way too fast. You have to at least slow it down. And the National Association of State Medicaid Directors, a separate group, wrote a sort of a blistering letter saying that there is no amount of flexibility that you can give states that would make up for the amount of money that would be taken out of the program.
And Don, you were mentioning earlier that you were thinking at some point with Caring about whether or not to become a Medicaid provider, but you put your brakes on that because of this uncertainty?
Well, it's a pause. We're still looking at other ways to bring in revenue to do the work that we do, but there is tremendous uncertainty. We look at the state of North Carolina, 1/5 of the population is on Medicaid. It's a huge proportion. 60-70% of the North Carolina Medicaid population is children. 2/3 of seniors in nursing homes rely on Medicaid. It is a huge social safety net, healthcare safety net in our state and across our country, and the kind of changes out into the future to shift Medicaid from being based upon need, you qualify just because you're poor at a certain level, to capping it and then allowing the state to decide, well, we may include work requirements in order to receive Medicaid, or we may have to make a decision about whether we're going to provide additional interventions for children versus additional interventions for the elderly. It introduces so much uncertainty into how we, and particularly people with limited resources, access insurance, that it makes it very difficult for hospitals or clinics or other providers of services to decide whether they're going to dip their toe into Medicaid.
And the fact that they're raising this by basically the rate of inflation, the set amount that the federal government will pay for health care capped, growing only along what is in essence the CPI, the same kind of thing that it's just basic inflation. Steve, you can explain, I'm sure, better than almost anyone, that the core rate of inflation that we as consumers are used to and that we see in other products does not track with medical inflation rates.
I would agree with that. And if you think about just from a practical exercise, just the cost of prescription drugs and the cost of technology. So the medical rate of inflation is indexed and tied to, these advances, but also, increased costs in pharmaceuticals, technology, et cetera. So ramping that down to the CPI, certainly, creates a pretty significant delta that'll impact hospitals. And, from a Medicaid perspective, I think it was said before, the vast majority of the people on Medicaid are children, elderly, and disabled. And there's been, just a silence in regards to what this possibly could do to, elderly that are currently in nursing homes that are dual eligible. Mm-hmm. So I think that's that's an important discussion as well, since we all know families and loved ones that that may be in these facilities for care. I think finally, North Carolina's performance in the Medicaid space is probably one of the best kept secrets in the country. If you look at over the past several years, since 2012, the overall Medicaid spending in North Carolina has been reduced by 15%. And under this bill, those states that have worked together to really focus on making healthcare more affordable, and that's been a partnership with physicians, hospitals, and others. In many cases, we're being penalized or will be penalized for the good work that we've done trying to, put a rein on, the cost of Medicaid and the increases that many other states have seen every year.
You're listening to Charlotte Talks, and we're talking, of course, about the plan to replace Obamacare that is now put forth by the U.S. Senate. I want to go to some questions. We heard from Dustin on Facebook, who writes, "This bill appears to be a bill that would handicap rural hospitals and force them to merge with large systems. Do your guests see this as a good thing or a bad thing?" Steve, do you want to start with that?
Well, having been involved in health systems that have embraced small community hospitals and brought them in as part of a system, I do think it creates additional financial pressure that will force, independent hospitals that are in small communities to take a hard look as to whether or not they can continue to go alone, especially when we're looking at not only reductions in reimbursement, but also the investments that hospitals have to make every year and in the future to ensure that they're offering modern, state-of-the-art care, but also to ensure that they're able to attract and retain, great people that are working in those communities. So I do think that it'll put additional pressure on small community hospitals. I think that they'll be forced with, really three choices. One is how they reinvent themselves and perhaps look at how they array their services, which may be less than what they're doing today. They may have to look at becoming part of a larger system to create financial security, so risk is spread throughout a larger economic and business footprint. And then third, some hospitals, like several throughout the state in the past several years, will be forced to close their doors.
Jessica writes on Facebook, and this is one of the more skeptical thoughts, and I know that she is not alone in this belief. As long as the insurance companies are in control, which they are, believe you me, nothing is going to change. Julie, do we know if the insurance lobby had much to do with this health care bill?
They actually didn't. They're in a very difficult situation right now. The Trump administration is kind of doing its best to undermine the existing Affordable Care Act so that they can, as the president said at one point, force Democrats to the table to negotiate. So the insurance industry is kind of frantic, at least those who are serving this individual market. And they've been, they've put out a few kind of tepid statements, but that's about it. The rest of the healthcare industry, as we've talked about, hospitals, the American Medical Association, the Medicaid directors, almost every doctor group have come out very strongly against this, primarily because of the cuts to Medicaid, which are, not only care for their patients but income for them, and the concern that they simply won't be able to, to keep their doors open or keep their practices, operating with these kinds of cuts. But the insurance industry is really kind of caught between a rock and a hard place on this one, and they've been relatively quiet about it.
I might just add, I think the insurance companies are just looking for clarity. They're looking for some sense of where the federal government wants to go with health care. I know in North Carolina with Blue Cross Blue Shield, the rates that they've proposed for next year are high, a 23% average increase, but they've said if they knew that the supplemental costs that would be coming back from the federal government was going to be there, the rates would be much lower. So the insurance companies, like the rest of us, are operating in this world of kind of limited information and having a very difficult time of deciphering where the federal government wants to go with health care.
And that's a really interesting point you bring up, Don, too, because they actually said the 23% rate increase that they asked for Obama, policies that are about on the health exchanges, would only be 8%.
Yeah, 8%.
If it wasn't for the fact that the uncertainty that basically is surrounding the marketplaces.
That's right.
You're square in the middle with CareRing. You're square in the middle, it seems, between Medicaid on one end and classic private insurance holders on the other. If this does come to fruition, if in fact the CBO score is accurate, you obviously would be left to fill the gap. And CareRing would be seeing a whole lot more people. Do you have the capacity here in Charlotte?
Not right now, no. We're part of a network of providers in Mecklenburg County called MedLink of Mecklenburg. So it includes the clinics with Novant and with Carolina's healthcare system, free clinics, some faith-based clinics, the federally qualified health centers, and us. Collectively, we're able to serve about 40 to 45,000 people that have fallen between the gaps. They don't have public or private insurance. If this were to go forward, I would anticipate, I can't give a specific number, it's more an art than in science, but almost a doubling of the need within our community. And so there would be a tremendous need for organizations like ours to have additional access points for people that don't have access to care. And it would be in the hospital's best interest to try to support us to do that, because otherwise these people would either go without care or they would show up at the emergency rooms.
So let's step back to, the big picture here, Julie, when it comes to Medicaid. The way this is capped, and it shifts costs down to states, at least in my reading of the bill, I don't think anybody can actually figure out quite yet how much of a cost shift this would be. Is that fair to say?
Oh, well, they know that it's more than $700 billion that the states would have to make up over 10 years. So, which it's interesting. It's actually slightly less than the House bill, but that's because the cuts happen more slowly.
And do we think the states can, we've got about 30 seconds here, do we think the states could possibly shoulder that burden?
No, the states don't have a lot of options. They could raise taxes, which most of them can't do. They could take money from somewhere else, primarily education. They could reduce eligibility, or they could reduce the services that are offered, or they can cut payments to providers. Those are all of their options.
Yeah, not a great list of options, to say the least. We're talking the Senate health care bill. We'll have more here after a short break. You're listening to Charlotte Talks on 90.7 WFAE.
Support for Charlotte Talks comes from WFAE members and Baby & Company, a modern birth center offering individualized maternity and well woman care, classes, and wellness services in an intimate setting. More information available at babyandcompany.com. And Ruth's Chris Steakhouse, featuring a steak and wine menu for business meetings, private parties, or dinner. Uptown location open for lunch and dinner, South Park for dinner. More info at ruths-chris.com. Coming up at 10 o'clock on Point, the healthcare conversation continues with a discussion at how deep cuts to Medicaid could hobble efforts to save lives. Tom Ashbrook will be joined by a panel to discuss how the healthcare bill could worsen the opioid crisis. That's coming up after Charlotte Talks at 10 on Point, here on 90.7 WFAE.
The ATM turns 50 years old this week, and whoo boy, has banking changed.
They used to give you toasters and have all sorts of fun things for you to do in the bank if you would open new accounts. It was a social activity.
I'm Kai Rizdal. Happy birthday to the ATM. That's next time on Marketplace.
Marketplace this evening at 6:30 on 90.7 WFAE.
This is Charlotte Talks on WFAE. I'm Tom Bullock, and we're talking the Senate health care bill with Steve Lawler, the incoming president of the North Carolina Hospitals Association, Julie Rovner, chief Washington correspondent for Kaiser Health News, and Don Jonas, executive director of Caring. We're going to get back to some more questions from you, our listeners, here in a moment. And if you have a question, feel free to email us at charlottetalks@wfae.org or search us out on search out Charlotte Talks, on Facebook or Twitter. I'd like to step back for a moment and talk about the law that, of course, this plan, the Senate plan, seeks to replace Obamacare. Everybody says Obamacare is hardly perfect. I think it's an important point to bring out. Let's take one of the most controversial provisions of the bill, and Julie, you brought this up earlier. It's called the individual mandate, which requires individuals to buy health insurance or pay a fine at tax time. Now, Dan Mendelsohn is president of Avalier, which is a nonpartisan health policy think tank, and he had this to say about the mandate yesterday.
I think that right now we have to acknowledge the fact that the mandate is simply not working. There are about 10 million people covered under the exchanges right now. If the mandate were working, we'd probably have about 25.
So my question is he right?
Are you asking me?
Go for it, Julie.
Yeah, this is one of the insurance industry's deal that they cut at the beginning of this law was we will cover people with pre-existing conditions if you will make sure we have more healthy people who buy insurance. Remember, we're talking primarily about the individual market, not people who get most people get their insurance through their workplace. This is only for people who don't have any other access to insurance and they buy it themselves. So obviously the people who think they're going to need it are the ones who are inclined to buy it. So the individual mandate was put in to try and encourage healthy people to buy it. What's happened is that in a lot of places, insurance is so much more expensive than the mandate penalty is that people are just paying the penalties. And I should point out the insurance industry said this at the beginning. This was a very difficult thing for Congress. They knew it would be unpopular. It is unpopular. So they didn't want to make the penalty that big because it was going to be unpopular, but if it's not big enough to encourage people to buy insurance, then it doesn't work. And in fact, it's not working that well. As we mentioned, the House and the Senate both have different approaches to trying to encourage healthy people to sign up. The Congressional Budget Office is not very excited by any of these approaches.
Janine on Facebook writes, can someone explain who pays for the uninsured care cost? As an example, an uninsured 24-year-old goes to the emergency room for an accident. Who pays for her care? Steve?
Well, that's a great question. First I would say that if a bunch of well-intending kind of smart folks sat down in a room and tried to figure out healthcare financing, we would all leave scratching our heads. Under the current system, those costs are covered in a variety of different ways. First, I think hospitals, physicians, et cetera, are there to care for those patients, but they're incurring a cost and an expense to care for that that young person that has elected not to have insurance. And in our current market, hospitals and physicians are negotiating with insurance companies really as partners. And I think for many years we kind of thought that hospitals and insurance companies were at odds and kind of in this tug of war. But in essence, we work together as partners to, figure out, how to not only ensure that, those people that are beneficiaries under an insurance plan are well cared for, but hospitals are also asking insurance companies to participate in social good and help cover the cost and expense of those non-insured folks. So I think the answer to the question is everyone, one way or another, pays for those people that do not have insurance.
And this is why it's important that 22 million Americans is important. It's not just the you can argue the moral or ethical grounds. It's the fact that those people who are uninsured, we all, en masse, help cover their costs.
And Tom, you should point out that if you don't have insurance and you go to the emergency room, you're going to get a bill. Mm-hmm. So the other thing that happens is that people have their credit ratings ruined because sometimes they'll get bills that they can't possibly pay. That's when other people sort of pitch in to make up for the bad debt. But the patient themselves is going to have to attempt at least to pick up some of the cost.
Now, sticking with the theme of Obamacare, and I am looking forward to the day where it's not always a presidential tweet that I'm reading, but yesterday President Donald Trump tweeted, maybe Republicans should just let Obamacare crash and burn. That has some really significant impacts, Julie, potentially for something like the insurance industry or the markets. I mean, what would happen if Republicans just let Obamacare crash and burn, to use the president's words?
Well, it's not that they're letting it crash and burn. To some extent, they're they're steering the car off the road. This is the big fight that we've been talking about with the uncertainty about whether or not the federal government is going to pay. These are required payments that the insurance companies give discounts to people who earn less than 2.5 times poverty, not just for their premiums, but for their deductibles and their cost sharing to make health care affordable for them. The federal government promised to pay them back. There's a very arcane fight, and there's a lawsuit about whether or not Congress ever formally appropriated the money. So what's happening is that the Trump administration every month is deciding whether or not it's actually going to pay this money back to these insurers who, by contract, have to provide these discounts. That's what the health insurers are complaining about. They have no idea if this money is coming, even though they're required to pay it out. If they're not going to get it back from the government, that's why they're asking for such big increases. So there's already, they're facilitating the crashing and burning of the Affordable Care Act.
Don, I see you nodding your head in agreement.
Yeah, well, I'm trying to process what could actually happen. I mean, if you would have a situation if the Trump administration decided not to continue providing the subsidies of in the almost immediate short term, some real chaos in the states from the insurance companies in terms of how they're going to continue to provide insurance products to people that are relying on these for their insurance. And I think allowing this to crash and burn, as the Trump administration wants to do, it may have some unintended effects. It may end up causing some of the more conservative, some of the more moderate members of the GOP with some other members of the Democratic Party to say maybe there's a grand bargain here. Maybe there's a coalition we can come together to actually really kind of fix what was wrong with the Affordable Care Act rather than trying to just throw it all away.
Steve, are you trying to get in? I keep hearing you back there.
Yeah, and I would say that I think that currently we're in a situation where you have two parties with diametrically opposed views. I think the Affordable Care Act really focused on expanding insurance coverage first, both Medicaid as well as subsidies for low-income individuals and small businesses. And their secondary interest and concern was looking at long-term cost reduction as kind of a secondary issue. I think for the Republicans, it's really about reducing costs first by curtailing federal spending on Medicaid and subsidized coverage, and then figure out at some other point how to deal with the coverage issue. So because you've got two groups that are starting at two different points, we basically have a situation where we've moved healthcare from being about people to being about politics, and I think when you do that, it's difficult to craft something that makes sense.
Yeah, I like that, Steve. This is Don. I just, when you think about why did we have the Affordable Care Act in the first place? I mean, there was rising costs and there were rising uninsured. Mm-hmm. And so we have, through the Affordable Care Act, very successfully beaten down that number of uninsured. But the rising costs, we haven't controlled that. That was, most of the analyses.
There have been cost reductions, though. It hasn't increased as quickly, I should say.
But it's still gobbling up 19% of the GDP in this country, and it continued to stay on that route if we don't make significant changes. And so I can, where you stand depends on where you sit. I can sort of see where a conservative, fiscally minded representative looks at the debt. We're looking at $20 trillion in debt, and the same CBO that has scored the Senate bill has also projected another $129 trillion in deficits over the next 30 years. So we are in a situation where the cost for health care and many other entitlements are truly unsustainable. There will be a point of reckoning where we've got to figure out how are we going to provide these sorts of services to people that are in need. And so that's where I think at some point in the relatively near future, the conservatives that are focused primarily on the financial health of this country and Democrats and more progressives that are looking at how do we provide an equitable health care system have got to come together to find some common ground on how we provide care in this sort of environment.
Yeah, and I would say that if you were to go to the provider community, hospitals, and physicians, in many cases we would say there's plenty of money in the system. I mean, how it's spent and whether or not it's applied in the most productive ways is something I think for us to work on. We spend about $10,000 per person on healthcare in this country, and a fourth of the population does not have access to preventive health and primary care, and our safety net is kind of riddled with holes. So I think, as part of the process, I would encourage our leaders to engage, people that are involved in doing the work, and ask them, under the guidelines that the money that we have going into the system is adequate to support the system. Design it. I think there was some wisdom back in the days of Rome when they would have the architect and the builder walk across the bridge or aqueduct first, because they were responsible for the construction and design, and it was
build some public
a
confidence.
way to make sure that it was safe first. Yeah,
Julie.
Yeah, I think the biggest problem right now is that the debate in Washington is all about who's going to pay instead of how much we're going to pay. Basically, what this bill does is it says healthcare costs are too high and the federal government wants to pay less, which is, as it has been pointed out, the federal government does have deficit and debt issues, but it doesn't do anything to bring the cost down. Now, there was a fairly legitimate complaint about the Affordable Care Act. It didn't do much to bring the cost down either, although it did lay some groundwork for some of the slowing that we've seen in increasing health costs. But basically, we're all fighting about who's going to pay, rather, how to slice the pie, rather than suggesting that maybe the pie is a little too big, and if we shrunk the pie, we wouldn't all have to pay as much.
Now, of course, this leads us all back to the magic number I mentioned almost an hour ago, 2, the number of votes the Republicans have to spare and still be able to pass this bill when they try to vote on it. It seems to be this week. Now, we invited both of North Carolina senators to be on the program today. Neither agreed. But here is a statement from Senator Richard Burr. He says, quote, "The draft legislation outlines a number of initiatives that are good for North Carolina. While not perfect, the bill does provide the funding we need to support our most vulnerable North Carolinians." So Richard Burr seems to be in the yes camp on this bill. And then there's Tom Tillis, the junior senator. His statement is more of a maybe. Quote, "I've said repeatedly any replacement plan must be a net improvement over Obamacare, and I look forward to carefully reviewing the draft legislation over the next several days." So, Julie, let's bring this back to that whip count. We've got one seems to be a yes from North Carolina, one maybe from North Carolina. Where do they stand overall?
Well, at this point, there seem to be at least 4 no's, firm no's. Dean Heller last week in Nevada, Susan Collins yesterday, Rand Paul yesterday. We've got sort of two moderates, and then it looks like Ron Johnson from Wisconsin. At least now, some of these are saying they don't necessarily want to say we oppose the bill, but they all oppose what's called the motion to proceed, which is to get on to the bill, which is kind of a delaying tactic. So, the first hurdle this would have to pass is that the Senate would need, 50 votes plus a tiebreaker vote from the vice president to even bring the bill to the floor. At this point, it doesn't look like they have that. But as I mentioned earlier, Senate Majority Leader Mitch McConnell now has a lot of money that he could theoretically throw back into the bill and still meet the budget targets that they have to meet. And I think today is really about seeing if he can cut enough deals to get enough of those, those no's and or fence sitters on board, at least to get the bill to the floor.
But even that comes at a potential risk of a vote. I want to play another thing that South Carolina Senator Lindsey Graham had to say.
If you're going to make any changes to get votes, I'm willing to do that, but I'm not going to do the Cornhusker kickback or the Louisiana Purchase. So the best way to lose me on this bill is to start buying people off.
And it's even more complicated than that, although Lindsey Graham himself would represent half of the votes that the Republicans could potentially lose and still pass this bill. There are also wings of the Republican Party, and it's important to note that no Democrats are supporting this bill. There are wings of the Republican Party, Julie, that are themselves at war with why they don't like this bill.
Exactly. Every time, McConnell moves to placate a moderate, he's going to lose a conservative and vice versa. This is the dirty little secret of the past 7 years is Republicans have been saying they want to repeal and replace Obamacare because that's the only thing they agree on. They have never agreed on how to do it. So conservatives want much more of a pullback from the federal government involvement in health care. Moderates definitely do want less of a pullback, and so it's going to be really difficult to, as I say, buy people off. And Lindsey Graham was referring to some of the deals that were cut at the last minute in 2009 because, remember, the Senate had 60 Democrats, but they were not using this budget procedure, and they needed all 60 of them. And to get those last couple of conservative Democrats, they had to promise some things that, by the way, were later taken out of the bill. They never did become law.
So we've got about a minute left, and overall, the one thing that really strikes me as interesting about this debate is, have America's politicians stopped fighting about whether or not health care is something that the U.S. government has to have a direct role in terms of coverage, and now it's just a question of how. That would be a significant change from Obamacare when it was first being debated. Julie?
Well, the thing is, the federal government already pays more than half of the nation's health care bills through Medicare and Medicaid. There's an enormous tax break for people who get their health insurance through their employer. Then there's smaller programs, Veterans Health and federal workers. So it's very hard to pull the federal government back too much unless you have something to replace it with.
Julie Rovner, Chief Washington Correspondent for Kaiser Health News, Don Jonas, Executive Director of Care Ring, and Steve Lawler, the incoming President of the North Carolina Hospital Association. They were our guests here as we talked through the U.S. Senate health care bill, and I want to thank you all very much for the hour.
Thank you, Tom.
Thank you.